Good morning, everyone, and welcome again to Part 1 of Finding Positives, Part 1 of a three-part series in the next couple of weeks. I'm Michael Diaz. I'm a Capacity Building Assistant Specialist here at the Commission, and I'm with my colleague, Bolivar Nieto.
Good morning, everyone. My name is Bolivar Nieto, and I am part of Juntos Construyendo. I'm the director, and it's a network that works with organizations and grassroots groups and college groups that target Latino, gay, bisexual men in New York State.
So before we get started, I just wanted to go over some housekeeping in terms of some logistical information. So at the moment, we have the lines unmuted. But you can, if you wanted to unmute your line, you can do so by pressing *6, okay? I'm sorry, press *7, I apologize. And to mute your line, you press *6. So at points, we will have, if you have a question, you can certainly do so by speaking up. Or we certainly have the chat option for those of us who are a little shy and don't feel comfortable talking. You can definitely use your chat option and send us any questions, especially if for any reason you have difficulty hearing the broadcast or you're not seeing the slides in front of you, anything like that, any technical issues, you can definitely go ahead and let us know through the chat option.
There's an additional feature that is called Raise Your Hand that you can use, and we will see it, and we will be able to unmute the line and or communicate with you via chat and respond to any questions you may have and bring it out to the entire group. We usually provide the question that it's been sent to us and facilitate a discussion around it. Also, this, as Michael was saying, it's the first part of what is a training that takes place over 2 days. We have adapted it in a webinar format, and it will include some homework, very easy, but it helps understand sort of like the different concepts that we're going to be seeing during these 3 weeks. It helps us adapt the information to your particular needs, and it helps us review concepts and emphasize information. Again, this is a working collaboration. We have put together this information based on different curricula that we have, based on the changes in the field of HIV, based on the different core competencies that are needed to implement interventions. But it's also, the other part is actually your expertise, your experience, you know the location, you know your target population, and together we can figure how to best approach our testing initiatives and thus finding individuals who are positive and linking them to care. So throughout the webinar, there are going to be some questions that are poll questions. On other occasions, we're going to request sort of like feedback. You can unmute your phones and facilitate this discussion. We understand that a webinar format is kind of different, obviously, than a face-to-face, but the participation is welcome. Finding Positives, again, was designed last year. It was implemented the first time in Puerto Rico during a mini training institute that happened in 2 locations. It was implemented in an urban area as well as a rural area. Michael helped put together the curriculum and was the first one to facilitate this in Puerto Rico, and also did an adaptation for Chicago. So I have a question. I'm going to unmute the lines and test the phone.
The conference has been muted. The conference has been unmuted.
Hello, can you all hear us?
Yes.
I can hear you.
Yes.
Okay.
Yes, I hear you.
Great, because we're having a question about testing the sound. How is the sound though? Is it too far, too loud?
Fine.
Okay. Okay. Thank you.
The conference has been muted.
So just to give you a little bit of background about who we are, we're the Latino Commission on AIDS. We're a nonprofit agency founded in 1990 by Dennis de Leon. You see his picture there. And essentially, it was started by a group of leaders in the community who wanted to address the epidemic, HIV, specifically in the Latino community. In terms of, people were dying, people had little access to health care, and just on top of that, add language barriers and undocumented status to that, and you can see the formula for severe health disparities in underserved communities. So we came together with that aim, and we have grown since then to provide services to more than 40 states, including Puerto Rico and the Virgin Islands. We have a long history of national, regional, and local coalitions, building collaborations and partnerships. Our work is sort of concentrated in 5 core areas, those being the Hispanic Behavioral Research Center, HIV prevention and health promotion, capacity building assistance, using our change approach or change model, and our SIVA program is what brings to you today this webinar on Finding Positives. We do HIV testing and access to care. So it's, which is important to note because we provide, we start off as grassroots, providing services to the community, and it informs us about the issues that go on, the issues that we have as providers, and we are able to make those comparisons locally, regionally, and also nationally. And also we do work in health policy and community mobilization. In terms of our capacity building assistance programs, we have 2 programs. One of them is Hands United, and this is capacity building for community-based organizations. And we, in terms of addressing needs and providing services, we meet multiple facets. For example, program infrastructure and implementation. This could be anything from like assistance with grant writing, leadership development, program design, program implementation, assessing the effectiveness of programs with data collection tools, with looking at monitoring and evaluation of information. We also provide capacity building assistance in the development and implementation of public health strategies, or implementing those strategies at your respective agencies, and also work with recruitment and retention. And that's Hands United. We are the Latino Commission on AIDS, but often people think we only provide services to Latino serving agencies. This is not true. Our services are free, and they are to meet the needs of all target populations. So that's Hands United. We also have Comunidades Saludables Ahora, or Healthy Communities Now, which is our capacity building for community mobilization. Under that branch, we have 4 main community mobilization models. One of them is our Latino Religious Leadership Program, which essentially works to build relationships between CBOs and faith-based institutions. We also address the needs of providers or agencies who are located in an area where there's an emerging Latino population, and the providers, for many different reasons, may not know how to best address the needs of those emerging Latino populations. Also under CISA, we have National Latino AIDS Awareness Day, which is our social marketing campaign, which is coming up. It's October 15th, and again, it's just to raise awareness among Latino populations about the importance of knowing your status and linkage to care. And we also have the healthcare worker mobilization model, which again, similar to the Emerging Latinos model, is to address the needs of Latino populations and sort of how to best equip health services and health-serving agencies to meet the needs of Latinos. So that's a little bit about our capacity building assistance team and endeavors.
Now going to the objectives that we have set up for this first part that is going to take approximately 2 hours. We are going to cover some of the foundations, and again, the foundations are related to the different changes that has been or are happening, national HIV/AIDS strategy, high impact prevention. We're going to talk about how this came about in terms of biomedical research and what is treatment and prevention, and how this informs or how, for example, HIP is operationalized, how to operate and how to kind of like adhere to what these guidelines are saying in terms of addressing HIV/AIDS nowadays. It's also important to understand, and in operationalizing HIP, we are talking about 3 different specific things that we're going to cover, but one of them is about understanding the interaction between behavior, environment, and the self. So far, with the Debbies and what's happened until the changes now, there has been a focus more on behavior equals maybe just the person, but research has shown that it's sort of like it's beyond that. It's a lot of different barriers and a lot of different structure settings that come into play when it comes to a behavior and thus a health outcome. So we're going to talk about that, and also we're going to talk about population segmentation. Population segmentation is more about, again, looking at individual in a specific within a specific component and generate what will be our population at high risk. So to begin, we have a poll. So, and you have it, and if you can answer, mark all that apply, and it's like I'm familiar with the information on, and if you can
take a couple of seconds to respond. Excellent. So we see here there is definitely a significant familiarity with this, many of these concepts, as we imagined. And the reason we sort of wanted to start off with that little questionnaire is just because we're going to talk about a little bit about these changes as a context, right? We know that, again, we always hear changing landscape, changing landscape, changing landscape. Many of us are kind of overhearing it already. Some of us are trying to figure out what this means to our significant or respective agency. So we're going to talk a little bit about that. And really, at the end of it, it's keeping in mind, that there is less resources, yet the work has not minimized, but we have less to do, or less resources to do it. In terms of thinking about these changes, we're going to focus the conversation on NHAS and also high-impact prevention. So really quickly, because I know many of us are already familiar with it, looking at the three main goals of the National HIV/AIDS Strategy is to reduce the number of new infections, increase access to care, right, as well as optimizing health outcomes for HIV-positive persons. And we've seen that there is a focus on working with HIV-positive people or working with positives. And that is one of the emphasis of the National HIV/AIDS Strategy and is also reflected in high-impact prevention, right? And, of course, the third goal being reducing HIV-related health disparities. Seems easy enough, right? But the truth is, depending on where we provide services, location, cultures and location, populations in those locations, the way to approach these things is to really have it be a customized approach. What does it mean to address these different goals for my population? And we're going to talk a little bit more about that. So here we have high-impact prevention, which is CDC's response to the National HIV/AIDS Strategy. And really, high-impact prevention is all about focusing on interventions and work that can be implemented and have it be scientifically proven. So a big emphasis on data, monitoring and evaluation, which I know as it stands, many of us as providers are caught up doing the work itself and often have less time to actually collect the data that shows the effectiveness of our programs, right? But however, this is being emphasized and as more funding opportunities are announced, it's going to be more and more. It's going to be underscored that much more. And in terms of looking at interventions being cost-effective, again, many DEVIs have been de-emphasized for one of these reasons, because a lot of money and resources, time and effort was going into these behavior interventions, yet the data says this is not working. We're spending a lot of money, a lot of time, a lot of energy, and this is not working. So there is an emphasis on making, using our resources, our limited resources, to work for us. Focus on scalable. So again, interventions that have been group level are sort of being de-emphasized. Community level interventions are being emphasized. Let's reach as many people as possible. That's the whole idea behind high impact prevention, right? And again, going along with targeted to the right population, we're going to talk a little more about that later, and in the right geographical areas. And what does prevention look like? What does interventions look like according to our location, right?
So in other words, as we kind of like being these two documents so massive, and knowing that within the different objectives in NHAS, you have a specific objective to achieve, and also the different approved methods under HIP. So we decided to be like, in other words, this is the what needs to happen, and this is the how. Sort of like this is what he proposes to achieve what National HIV/AIDS Strategy has proposed for all of us to achieve. So the reduction on incidence by 25%, then we have to look on the other one, how. So we're talking about enhanced HIV testing, antiretroviral therapy, that's linkage to care, or access to condoms and sterile syringes, that's the structural interventions, prevention programs, and so forth. So the what is what, if you see sort of like in a logic model, this is sort of like my objective, my outcome, and this is sort of like my activities, the how. And doing all that, as Michael explained it, maximizing limited resources, which is about scalability of the scalability of program, and or what is called the prevention toolbox, or the combination prevention toolbox. What of these strategies do I have, can I combine to achieve what the National HIV/AIDS strategy is asking for all of us to achieve as the U.S. So sometimes it looks as I was explaining it at a meeting, it's a macro level, but look at it at the micro in terms of our agencies, what we do, who we provide services to, what we have in our programming, who we have and the expertise that we have, and then being able to create that combination of prevention toolbox to address HIV in our territories.
Okay, so here quickly, we have the treatment cascade. I know many of us are familiar with it. And the reason we always like to start this conversation with the treatment cascade is because it's visually, it tells us where the service gaps are. Visually, it tells us this is why we have high impact prevention. The focus is on moving closer to the medical side or linkage to care, right? Making sure that people are being linked to care, stay in care, that they have access to the proper antiretroviral therapies to reach this viral suppression. Because the theory being more people with suppressed viral loads means less of a chance of the virus being transmitted, right? And so what I often ask providers individually is to look at this cascade and say, where do I see the largest, fall in terms of the cascade, the largest discrepancy, and how can I address that at my respective agency, right? So in terms of looking at the total number of people who are infected, then of those only, again, this data is from 2010, and this is nationally, the national cascade. We're going to move on to the Florida cascade in just a second, but I wanted to start off with this, looking at the macro level. The drop, 83% are actually diagnosed. Of those, again, total, only 71%. So we're already dropped to roughly 30% who are not linked to care. So people who are HIV positive, they are not linked to care. And again, it continues to fall. And again, it's all about just looking, it's not about memorizing the numbers, but about where can I intervene? Where can we intervene? What are our strengths as an agency? Now, again, here quickly, it's a cascade, but it's been adapted for Florida. Okay, so this data comes from the Florida Department of Health. I focused here on the three bubbles because this is where we're going to focus our energies in the conversation, right? In terms of these, the people, clients, patients who do not know, who are HIV infected but don't know it. It's about targeting them. It's about, and also targeting high-risk negatives. Routine testing, and what does that look like at our agencies? And timely linkage to care. And again, what does linkage to care look like at our respective agencies? And what is the follow-up processes for that? And again, we can have more of those conversations as we go on in the series. But these are three main areas where we can focus our attention on to keep the conversation going and knowing really what is this all about. It's about finding those positives. And finding those positives is not just about doing the test itself. It's about the beginning of a process for linkage to care. And to address all of these health disparities, right? But again, we have to start with the test and our outreach efforts and our targeting efforts. So we have a question here, and the question is the treatment cascade similar to the community viral load suppression? So it's not the same, but they get at similar points, I guess is the best way to explain it. In terms of community viral load, that is more difficult to measure. I think San Francisco has been successfully in measuring community viral load, but it's still a lot of data is being collected, a lot of processes, and so it still no works. But in terms of looking at community viral load, in terms of what certain communities are more impacted, and then how is that going to put people at risk, which we then go into networks and the risk of being part of certain social networks versus others, and that is the tie. So absolutely, that is the connection between these two.
And we have another question, and it's sort of like around these new interventions, and one of them is about the biomedical research and the so-called PrEP as an intervention. It's like, who will pay PrEP? So it's a very good question. However, it's something that we're going to answer it towards sort of like the third session of this, when it comes to the combination and what does that mean, the prevention combination. And we will bring things that are happening in terms of medical insurance and ACA, so that will come into the conversation. That's a very good question, a valid question. It's a question that has happened, and it's happening, it's being asked, and we will address it then.
Again, here, and this is looking at national data. And really quickly, I'm a very visual person, and it just helps me to sort of contextualize what we're talking about, right? Here in the figure, you see that if you look at the bottom, the purple section, where it says 25% of unaware of infection, and yes, this results in approximately 54% of new infections. So it's the people who haven't been tested, don't know their status, and that's really important for the work that we do. This is what Finding Positives is all about, and sort of how do we address this really important and urgent need.
So as we move forward, we have another poll question, which is, in your experience, work, what are some of the barriers to finding positives that you have experienced? There may be more than this, but we have 6 potentials. Some of them are related to what we're going to talk about.
Yeah, we're aware that this is not an exhaustive list, but it's just, again, a list to work with and to give us an idea about some of the challenges that us as providers are undergoing. So take a couple of seconds and enter those, please. Okay, we're going to go ahead and close the poll. Thank you so much for your responses. So we would, wow, this is very, very interesting. We always like to hear more about some of the challenges that individual agencies are sort of addressing at the moment, or trying to address. So can anyone perhaps elaborate a little more about some of these challenges? So when you say stigma, what does that look like for your particular agency or a network of agencies, or acceptability of testing? We would love to hear from participants.
So we're going to go ahead and unmute the line.
The conference has been unmuted. The conference has been unmuted.
And can someone provide us as to why, for example, acceptability of testing?
Good morning. This is Felix Rivera with the Florida Department of Health in Palm Beach County.
Hello.
Good.
Morning.
Good morning. Good morning. Something that we've noticed here as far as acceptability of testing, at least that I've noticed, is particularly among definitely among the Latino community, but the MSM community and the coupled MSM community. We're testing more and more couples HIV positive MSM couples, and what we're finding out is, they weren't accessing testing because they may have been in a relationship that may have 12, 24 months, and when you're providing post-test counseling for these clients, sometimes they don't want the partner in the room, and you're providing them with that HIV positive test result, and you find out at that point that there's been risk, there's been sexual relationships outside of their their relationship, and of course we know that probably was the route of infection. So I think that's as far as acceptability of testing for those communities in specifically here in Palm Beach County, I've noticed in Florida.
Thank you for that comment. It's very interesting, and that's something that we're gonna talk about when we go into kind of like what we call really target population, and it's one of the things that we sometimes talk about. It's relationships and how does network level risk and relationships, and or sometimes maybe the fact of the challenging of maintaining condom use in a relationship, it becomes a challenge. It's something that we're gonna address. Thank you so much. And also we have another comment on the chat box, and it's it's about defining who is at risk, and it's that with transgender populations, identifying risk based on identity rather than behavior is a problem. So, and again, it's something that usually lead us to sometimes just go to a specific networks and areas and do testing and continuous testing. And if we think from a math point of view and our seropositivity rate, if there is not a clear definition of who is your at-risk population, and testing is happening, and finding kind of finding and not finding positives, the amount of testing that you do it versus the finding positive, it's gonna create I don't know if I'm explaining, but we'll do it towards the end. But it's sort of like your denominator is big, so the amount of finding positive is, or seropositivity rate is going to be smaller. On another example that we have found is that, for example, an organization tested 16 people, and they had a seropositivity rate of 100. So it's sort of like they were very focused, very specific, very targeted, and they included networks. This is that we're going to talk about.
Thank you again for those questions. We're having a really good conversation. And again,
the conference has been muted.
Keeping in mind, again, the focus, high-impact prevention, challenges that we see in the field as we move towards implementation of high-impact prevention, and really defining and solidifying more so what is that? What does high prevention look like for our agencies? So in terms of testing, you'll hear, and I'm sure you've heard it already, a lot about enhanced testing. Well, what is enhanced testing? A couple points of defining it is it's really looking at or testing individuals who've never been tested before, right? Again, those 20 or so percent, right, who potentially lead to 54% of new infections. Also, individuals unaware of their status, individuals with high-risk behavior. an increase in a number of people who have received an HIV test in the past 6 months. So again, like looking at retesting for people who are at high risk, and increasing the number of people diagnosed early. We know specifically that, or research data shows us that Latinos are very infamous for being late testers, right? They're not getting tested, and we, again, a lot of theories and a lot of, again, more data that tells us why, that addresses and identifies those social determinants of health that we're going to talk a little bit more about. And again, this is with one population, but these are the types of conversations and assessments that need to be made, that need to be part of the conversation in terms of finding positives, and what is that process going to look like. Bolo talked about operationalizing high-impact prevention, or HIP, and what is HIP? Looking at the bigger picture, what does it mean for us? Really, this is what it's about. It's about redefining our target population, finding those positives, as we keep mentioning, and also strategizing and knowing what protocols or identifying how are we going to implement potentially new protocols. How are we going to change our strategies, assuming we need to, right, to address that need in terms of implementing enhanced testing or doing enhanced testing. Combination of interventions. Now, this is all about, in that figure that we looked at, the what, NHAS. So NHAS has all these objectives, right, that have to be accomplished, or we expect to be accomplished by the year 2015. And then the how, in terms of CDC's response, CDC is looking at all of these interventions, including biomedical interventions, emphasis on testing, linkages to care. Again, looking at a combination of efforts that have to come together, and it's all part of the process of finding positives, of linking people to care, of making sure that people stay in care, right? And again, as an agency, looking at identifying our own strengths, but also identifying opportunities to work with other agencies potentially, and build on these collaborations and partnerships to enhance this work of finding positives, of linking people to care.
And but when it comes to kind of like creating a training, creating information that provides some sort of like skills building, my biggest questions in our CIVA team was, okay, HIP is mentioning that we have to target at high-risk populations, but we have been targeting at high-risk populations. So for me, the understanding of what is it meant now, what do I understand by at high-risk populations? Is risk a constant? Does risk changes? Is it about networks? Is it about my individual and how I behave? Is it about my relationships? Is it about my values, or where my values interact in my social surroundings? And then it comes the combination. One of the questions, we're talking about PrEP. Is that available? Who is eligible? How do I do this screening? And that's an important part. And then the screening comes with links to the combination of approaches that you're going to have, and also the partnerships. So a way to kind of like put it in a diagram created is, okay, this is high impact prevention. The first thing that we need to do is, do a target refinement, and that's kind of like our goal here. Here we have the formula that B equals a function of B and E, and that's basically behavior is a function of the person and the interaction with the environment. So when we talk about environment, we're talking about the social determinants of risk. We're talking about structural barriers and the self. During the poll, we saw that stigma was one of the barriers. That's a social determinant of risk, but stigma interacts with structural factors of, for example, the acceptability. In relationships, some values prevent the acceptability of testing because they might not perceive themselves at risk. So we're going to work on this target refinement, and this target refinement lead us to testing, and that will lead us to either result. If it's at high risk negative, a person who's negative, because of your target refinement, this person is considered at high risk negative, and then they will be sent to kind of like the context, what we call, or the prevention toolbox, which is these innovative strategies that emphasize a holistic approach, looking at the person and the environment, talking about structural interventions, which is condom distribution, accessibility, availability, and acceptability of using condoms, interventions, focus on behavior, and we still have some that are still approved, and then we have biomedical interventions. And with PrEP, it's about not only accessibility, but it's also adherence. For now, there's some research still going on in terms of the operationalization of PrEP in a maybe severe community setting. The other side of it is if it's a person who tests positive, then the prevention toolbox looks a little bit different. We're talking about linkage and maintenance in care for newly diagnosed. If it's someone who has fall out of it, if you see the cascade, have been diagnosed but maybe not in care, or have been in care, got disengaged because of A, B, C reason with the service provider, or because, you know, the idea or notion of starting an ART regimen is scary, or the accessibility, no insurance, so they may fall out of care. So there's a process of reintegration and maintenance, and also help with behavioral interventions, public health strategies, and biomedical, which is sort of like what we talk about treatment as prevention, and adherence. That's where it comes from these studies, that, you know, someone who is adherent to the medication, undetectable, is less, there's less risk of transmission. So, and that's sort of like the goal, and that's the emphasis of, like Michael showed before, those who do not know their status are unaware, and therefore the transmission risk is higher for those that don't know it, having it tested. Those that know may be in this kind of like undetectable phase, and therefore, they, even though they might be engaging, maybe sometimes in relationships in unprotected sex, but because of the viral law and it's undetectable, there may be less transmission. And we also have to take in consideration the biological aspect of it, in terms of whether it's a gay relationship, whether it's a heterosexual relationship, so forth. So we're going to go, before we go into sort of like target refinement, we're going to go into a series of questions and statements. And we would like for you to kind of like let us know if you agree, you feel neutral, you don't agree. Here's the first one. MSM risk has little to do with individual risk.
Okay, we're going to go ahead and close the polls now. Okay, so we see in terms of the statement, MSM risk has little to do with individual risk. We have a significant amount of people who disagree and or strongly disagree. Okay. So we want to explore this a little further. I see, oh, it's still coming in. So anybody, we would love to hear from anybody to tell us and hear more about why you disagree or strongly disagree, or whatever you selected. So we're going to go ahead and unmute the lines. And please feel free to speak up, or again, also you may use the chat option if you prefer.
The conference has been unmuted.
Okay, so again, if anybody would like to share their thoughts as to why they selected their option.
Good morning. This is Felix Rivera again from Florida
Hey, how you
Department
doing?
of Health. Good. You know, I voted neutral, and my reasoning for that is, you know, we know it's behavior that transmits the virus rather than, you know, any target group. You know, we know that unprotected sex is, you know, highest, you know, there's a higher rate of transmission having unprotected anal sex, and we know that, you know, it's not just men who have sex with men that are engaging in unprotected anal sex. So again, that was my reasoning for you know, choosing neutral.
Thank you, Felix. Thank you so much.
Mm-hmm.
Anybody else?
We have a comment saying that risk is more individualized based on relationship status, kinds of sex engaged, and such. So I still don't know if it's an agreement or disagreement, but it's interesting to see, and we're going to actually discuss this more in depth. So we have a next one, and this African American male living in a specific geographic area is at higher risk because he is Black African American.
Go ahead and take a couple seconds to respond.
I'm neutral on that one.
Okay, we're going to go ahead and close the polls and see the results. We see pretty significant difference, large amount of people who either agree or strongly agree. Again, we also, there's definitely, it's balanced, a little balance between disagree and agree. Okay. Again, anybody who wishes to reflect and share their response, we would love to hear it, either over the phone or using the chat option.
We have a comment from the chat talking about risk is also not the same for sex partners that take different roles in sex. And I think this is going to the previous one that we had in terms of risk. Go ahead to the next one. I mean, we're going to go into each of these.
The next question is, Latino MSM recently migrated to the U.S., not yet assimilated to a gay subculture, are at less risk. Take a couple seconds to respond, and we will review all of the responses following.
You want me to answer the question for you, sir?
And close the polls and review the responses. So we have a significant amount of people who strongly disagree and or disagree. All right. Again, please feel free to share your perspective either via the chat option or over the phone. Okay, so we have somebody, a question coming into the chat option.
Actually, it's a comment based on the previous one. As we get kind of like maybe responses based on the chat, it's about the young African American, depending on the geographic region. A comment saying that race is a reason for negative social economic determinants, not behaviors that put individuals at risk. So we're talking about these external factors now. We also have that cities are more densely populated and often have higher concentrations of African American of lower socioeconomic status. This group in general is at risk for poor health and disease. And we have, in terms of this new one, that Dr. Ayala presented some information on the protective factor of these social networks. So I would like maybe more elaboration on this. I haven't had one yet, but it'd be great if you can share a little bit more information. And then there are so many other factors to consider, agree. Questions that are too ill-defined to have any relevance. MSM are always at mute the lines, and we're going to go into kind of like dissecting each of these statements.
The conference has been muted.
So we have one more comment who came into the chat option, two actually. So first one, gay culture tends to promote sexual health and responsibility these days. Now that stigma is being reduced in that community. Okay, thank you. And then we have another comment, says, Latino MSM recently migrated may not be fully aware of risks in the new culture or geographical area and will not have adequate information to assessing their own risks. Excellent. Thank you so much for sharing that. Okay, so we're definitely going to keep this conversation going. Thank you so much for your responses. I think, okay, let's see, next. Oh, another comment. Sorry I missed the comment period. Let's see. Oh, just a technical difficulty. Okay, we're going to move on next. All right, so here are our responses. So number one, MSM risk has little to do with individual risks. MSM are the most impacted by the epidemic. And in terms, again, we know this, think of concentration of epidemic. And although being MSM may place a person at risk, individual behavior may not, because risk is not a constant. It varies for each person. So similar to what Felix and other people were sharing, is that if you look at it individually, the risk behavior clearly, right, does not dictate individual behavior. Risk, again, is not linear, nor is it constant, and it does fluctuate significantly on an individual level. And the reason, and we have all of these statements that we're sharing with you today have been taken from research studies, which we can definitely forward those to you from the Lancet. And so the statement is quote, accurate, because again, looking at individual risk versus the MSM risk. And in prevention, and especially in testing, where oftentimes we are, or the field sort of programs testers, so to speak, to look through the lens of risk. So it's like, okay, so if my target group is Latino or Black MSM between the ages 13 and 14, that is what I'm looking for. Those are the people that we are defining at risk, and therefore the interventions or the outreach efforts are going to mirror that. And oftentimes that doesn't always capture these individual differences or individual nuances, and that's what we're going to talk a little bit more about. It's what is it that's putting people at risk. Just being clearly identified as gay or just the fact that you have sex with men does not automatically put you at risk. Again, you have to take into consideration networks. What are the social networks? What is the concentration of people? And again, in HIV, how is HIV influence in those networks and the social structures? So what is present in terms of social structures, who are the sexual partners, again, they're having sex with, and what does that pool look like? And again, we're going to go through each one of these, and certainly we will open up the lines for discussion. Number 2, Latino MSM recently migrated to the U.S., not yet assimilated to a gay subculture, are at less risk. So again, this statement is also accurate in terms of looking at assimilation. Assimilation increases risk. Or the study demonstrated that assimilation can increase risk, right? It's a connection to bigger networks and network level risks. So really, even simple terms, this is certainly not about upholding stereotypes or generalizing gay communities. This is not what this is about. It's just about thinking about, as a person who arrives, what do I have access to? Who am I connected to? What do my social networks look like? And as we know, we work in this field, we know that particular social networks do put us at risk, right? Because networks are made up of people who share specific behaviors who may also have ties to specific spaces. And again, we can continue to sort of unpack this and dissect it a little more. But assimilation, looking at assimilation as a factor, certainly is very relevant in assessing risk, individual risk. And we also have, in terms of statement number 3, a young African-American gay male who lives in a specific geographical area in the U.S. is at higher risk because he is Black African-American. Again, thinking about different factors that are interacting, including geography. HIV is, as we know again, is higher in certain populations in certain locations, and there may be a larger risk pool, meaning more of these, again, social determinants that put people at higher risk. And I know for statement number 3, it was sort of a balance between people who agree and disagree. So again, this statement is accurate, again, for the reasons that people shared in terms of looking at spaces, geographical location, community viral loads. So I would love to open up the line and hear your feedback.
And I just wanted to comment also that the idea of bringing these kind of like examples that were presented during, for example, the International AIDS Conference, is to look at these social determinants and to look at the definition of being at risk varies. And as we saw it before, it's not just about identity, it's not just about behavior, it's about kind of like this interaction that happens. It's about not having access or having access. It's about, when we talk about the certain locations that may be at risk pool, we're not talking about the amount of people. It could be not that many people, but because of the concentration of, then you might be prompt to being at risk, even if it's sometimes one sexual relationship versus different locations when there is not. So, yeah.
The conference has been unmuted.
So we went ahead and unmuted the lines. If you'd like, please, we would love to hear from you any discussion pieces or any responses you have to the information provided.
Hi, this is Alex with the Florida Department of Health.
Hi, Alex.
I like the point about assimilation, but I also wanted to talk a little bit about the point that Dr. Ayala made in a recent conference I was in Seattle, where the depth of a social network has some protective factor on a person. In other words, a person who has close ties, good friends, family, who has an expanded social network that upholds him, let's say by checking in with him when he goes on a date or when he's meeting a guy or afterwards, checks in with him on where you stay, questions like that, or be safe out there, can provide a significant protective factor. And a person who's isolated, who doesn't have those kinds of people in their lives, may put themselves at more risk. And that's where my comment came in about the deep social networks.
Oh, absolutely. Thank you so much for sharing that, Alex. No, absolutely. Looking at assimilation, it's not a one-size-fits-all, right? Assimilation and how do we assess how it influences particular individuals and particular social networks, depending on those social networks and the support in those social networks, is absolutely going to help act as a catalyst to healthier decisions and healthier health or better health outcomes is the best way to put it. So absolutely. And actually, we're going to talk a little bit more about factors such as social support in networks, or as you said, the depth of networks, because as we know, that plays a huge role in this work and in terms of identifying and talking about risks and redefining risk and redefining our target populations.
Yeah, and again, it's sort of like at least these and the explanation of it helped me understand in terms of kind of like this redefinition of who is at risk, because it's not redefining MSM, it's redefining what are the different circumstances that and experiences and determinants that may place these individuals at risk. And with that, we sort of like, again, look at this formula, and the behavior is the result of the population characteristics plus of health, structural, environmental factors. So risk depends on network level risk, partners, social structure. And so we're gonna mute the lines now.
The conference has been muted.
So it's sort of like there was a focus before on just population characteristics equals this, sort of like not maybe being self-identified gay men, immediately I need to get tested. I may not be at risk depending on my circumstances. So it was the jump between population characteristics equals the behavior. But we're going back into looking at these determinants of health and the structural and environmental factors, including unemployment, homelessness, living conditions, stigma, social support that was mentioned, and so on. So this is not the limit of the list, but it's sort of like that continuous reassessment and assessment, a formative assessment of this population, including these different factors. So that's what we meant by kind of like redefining the target population, which is what we saw in terms of the formula. What is who is the P, what's the E that puts this population at risk? And the way we do it sort of like what we call an enhanced formative assessment. So formative assessment is usually recommended when you are planning an intervention, we are implementing an intervention, but it's recommended to be a continuous process, meaning like, okay, since communities are not static, I mean, things change from day to day. trends change. Usually it's recommended to do it like every 2 years, but with these new changes and with what we are now seeing, okay, what places the population at risk, we have to assess now in a more continuous way. What is the environment? What is the circumstances that may be placing people at risk? For example, now it's changing to have like the conversation on Affordable Care Act, and we will deal with that. But what does that mean in terms of a change in accessibility, availability of services, accepting services? What would that look like, and how does that then place people at risk or not? And sort of like it provides a better understanding of also who the target population and the needs. We look at the experiences of the population in the environment. We look at those social, economic barriers, environmental, etc. So, and it's very important because it helps us implement. And what we're implementing is sort of like a structural intervention. So testing is kind of like a structural intervention because sometimes some of us, we do it in the field. We have our testing vans that we have to go. So we have to deal sometimes with these social determinants such as stigma. How does stigma in a neighborhood impact my services? And that's sort of like what we want to do in terms of mapping stigma maybe and how to address stigma while at the same time delivering services. But that's going to come along. But this is sort of like what we recommend organizations to continue doing. I mean, it's something that helps reassess who the population is, what are the environmental barriers, and so forth. So we have the different steps. It starts with the data that is both epidemiological data. We talk about also data indicators, physical indicators, also that helps us define who the target population is, which is talking about person in this case, but also the environment, evaluating internal staff and their experiences. Here it comes your expertise, your experience. You see these changes. You can bring up this information and have sort of like this discussion as to what this may look like nowadays in a specific neighborhood. You are the experts. Conducting these interviews, but sometimes it's observational hours, not necessarily a lot of interview. And a lot of the things that play here, part here is that the screening. What's your screening in terms of the form that you have created? What is it based on? Have you adapted it? Does it really capture the information that helps you define whether a person is at high risk or not? And we will look at it. So it's going through these different steps. Some of them do not need to happen. This is sort of like what we have as the standard to conduct informative assessment when you are planning an intervention, sort of like for maybe grant writing purposes, but it's also for quality assurance, and it's also for adapting, and it's also for kind of like revamping maybe your intervention that we have, focus groups, and the mapping is important, and we're going to look at it. But right now we're going to focus today on the person, and that's kind of like segmenting, redefining who is the population, what is the environment will come next week, but now it's who the population is.
Again, quickly, and again, in terms of talking about formative assessments, it's certainly an important process to this idea of re-strategizing and changing our work, right? Because many of us know that it's either certain practices or interventions haven't worked, or maybe the way they look like now doesn't work. So that's why we really encourage this critical assessment, which isn't, again, we're not saying go out and start collecting massive amounts of data and analyze it, because we know people don't have time to do that, or resources to allocate for that. However, we still encourage the importance of implementing some of those components of an enhanced assessment into your interventions, into your finding positives. So looking at population and being more specific and unpacking a little more what's your population and what are going beyond, for example, and I used this example prior, I said, or assuming my population is YMSM, Latino, between the ages of 14 and 20, right? That's just going to start off with that example. Looking past that, so we know that that's our lens and that's can be our target population, but what are some of the other structures? What is also happening in those environments? Who are they connecting with? What do we know about those social networks, right? And we all have access to this information with, for example, depending on our target populations at the moment, intakes. Our intakes, our screening protocols, our risk assessments, all of these are valuable pieces of information that are informing us about our clients and our target population. So it's really one of the points we want to highlight is to encourage the use of that data, encourage the use of more, of unpacking these populations a little more, and what are the characteristics, which may or may not look different from our current target populations, okay? And part of that is using indicators. We have data indicators, and also physical indicators. We're going to talk a little bit more about physical indicators in the next two webinars, the other parts of the series, which gets a little more into, I'm going to say community mapping, right, or at least doing community observations and marrying it with what we're learning about our population or what we know about our populations. So in terms of data indicators, it's, again, information that doesn't explicitly tell us why something's happening, but it certainly tells us that something is going on, and there's a story here, right? Data is always a beautiful way of telling a story, or can be. So here we have, really quickly, it's graphic, it's visual, it tells us who are the populations, and again, this is EPI from Florida from 2011, telling us a little bit about what are those populations that are being impacted the most, okay? It's broken down by gender, depending, again, on our target populations, and also race and ethnicity. So the second one, again, very visual, looks at transmission, modes of transmission for men. No shocker here, right? We see MSM, and then we see through heterosexual contact. So again, sexual contact. The next slide, again, briefly, another graphic. This one is even more colorful, and sort of the numbers speak for themselves. But heterosexual contact among women, again, a story about. This starts to tell us about the people being impacted, those populations being impacted. But let's go beyond the numbers, right? What are these experiences? And that's what this is about. This is what finding positives is about. This is what enhanced assessments are about, right? To begin that process of deeper discussion about who are we targeting, why are we targeting them, and how are we using the information that we have access to, okay? And to capture both of those pieces, we acknowledge the behaviors that are putting people at risk, right? We acknowledge the personal characteristics that we're looking at, and we're encouraged to think a little, to perhaps even go a little deeper into including other characteristics that are part of that definition of who's at risk. And a huge part of it, as we mentioned, is the environment. What are those environmental components, right? What is the environment? What are those experiences that are leading to these rates, to these higher modes of transmission that look different? Of course, they're going to look different for women and men across sexuality, gender, and also race and ethnicity. So in terms of, those were just some quick indicators, right? It's valuable indicators that we start to tell the story. But again, we need to go beyond the story. Here we have a model. It's the Anderson's model. And it's essentially a conceptual model that addresses or talks about the factors that lead to the use of house services or not. Like, why are people accessing services, or why are they not? And I know many of us know why, right? We know we have information. We talk to our clients. We know that it's because of, access, perhaps undocumented status, perhaps they don't have insurance, money, lack of transportation. So, we know that all of us who work in the field and share an expertise in the field, we know that this is happening. So then the invitation then becomes, well, how can we get a more clear picture, right? Let's be more specific about what are these social determinants and how are they drawing people together, how are they drawing networks together. And this model specifically, which is relevant to the conversation we've been having, is that it talks about the environment from a perspective of healthcare systems and why people have access to certain healthcare systems or not. And more specifically, looking at the population characteristics, right? Looking at those predisposing characteristics, looking at those enabling resources and the need of the population. And we're going to talk a little bit more about what do these terms mean, right? In terms of predisposing characteristics, it's what are those demographics, race, gender, age, those things we have little control over that predisposes us to particular experiences, right? Along this is also health beliefs, right? So if I believe that accessing healthcare I'm going to feel better if I access healthcare, I have this positive correlation between accessing healthcare and also knowing that that's going to lead me to more positive health outcomes. And access, odds are I'm going to access healthcare, right? Make it to my doctor's appointment. But again, it's more talking through the screening process, is talking to people and understanding how this works and why it works in particular dynamics or under particular dynamics. We are going to we post this question here: how can we find or how can we use this information to redefine our target population? And it goes along with what we've been talking about. And looking specifically at some of these components. So predisposing characteristics, as I mentioned, looking at demographics, and also looking at social structures such as education or access to education, occupation, ethnicity, and other factors measuring status in the community. Coping mechanisms, or understanding how particular people, particular individuals, or people in communities cope. Right, so measuring what is happening and how are they implementing certain coping mechanisms, and how do they differ from other communities or other target populations. And the health of our environment. So again, thinking about living conditions, thinking about access to services, thinking about things also such as our enabling resources, right? Employment, housing, social support, which Alex mentioned earlier, the significant relevance of this component in understanding the depth of networks. And all of these networks are all contributing to that story. All of these indicators are contributing to that story, which also involves the perceptions of need and use of health services. So over the years, the Anderson model has had some adaptations. People use it to assess how particular populations are accessing healthcare, and it really takes into consideration these health beliefs, which we know come oftentimes from social norms, cultural norms within specific cultural backgrounds, right? And how these are just examples, attitudes, how this knowledge or belief can put people at higher risk, or how the existence of support systems actually acts as a facilitator to healthcare, as a facilitator to positive health outcomes. Any questions? I know we have shared quite a bit here, and I definitely want to open up the lines for any feedback that you may have, again via chat option or over the line. So we're going to go ahead and unmute the lines.
The conference has been unmuted.
Okay, so we're going to keep it moving.
You know him, and you know how hard
conference has been muted.
So again, capturing along with what we've been talking about, thinking about who this population is, what are their experiences, what social networks are they part of, how do they navigate spaces, right? And here again, we certainly part of in a formative assessment or enhanced assessment is being able to identify those peers, those people who have access to the education, which many of us do have peer education programs or peers working at our agencies at the moment. So really, again, encouraging to really use those tremendous resource, because these are gatekeepers, as we know. These are people feeding information and are aware of the changes and the trends in the communities that are either providing barriers to healthcare or facilitators to healthcare. And really, again, we keep emphasizing this. High risk depends on networks, level risk pools, the partners and social structures. So it's getting looking at the information we have access to and really dissecting it further to get to the core of who is this population, or we all have our target populations. What additional information can help me in this process of finding positives? And this is what this is about. Again, holistically, looking at person, looking at what makes up their experiences, and each of those relevant factors of their lives, right? Beliefs, social networks, and those personal characteristics.
So the way that we approach this sort of like segmentation, as Michael talked about, like we do population characteristics and environment, and further here we go the predisposing characteristics, enabling resources, perception of needs. When it comes to actually sort of like the skill development, we create kind of like this persona. So and we do a brainstorm of idea, considering again the information that we have so far provided and also looking at research that is out there that is talking now about social determinants of health, looking at what is network level risk, look at individuals at high risk. It's about the pool, partner, social structure, looking at relationships, looking at the sexual role, the versatility of gay men, or as they call it, the flexibility. And one of the questions that happened at this conference was like, so why is it the incidence is bigger among MSM than other sexual interaction? And it again goes back to also that versatility, meaning that a male can be both the insertive or receptive partner at any point in any given time. So it's sort of like that enhances the possibility of transmission. So we have to think about that as well. So the way we go about doing this, and sort of like this is kind of the homework exercise that we're going to recommend for you to do as units or organizations together. A brainstorm of idea of I have a defined target population maybe in terms of age. So it's recommended to segment it by age. Because the experiences that a 51-year-old has is different than a 21-year-old has, and in between. So we have to kind of like take, when we talk about experiences and interaction and social networks and structures, the experiences in terms of these different age groups are going to be different amongst themselves, even though they might be MSM again. We talk about also ethnicity. And here we may think about, yes, ethnicity, but these ethnicities come with certain core values and moral values, things that we're going to look at when we look at a stigma and have different ways of approach or interact within a setting or a specific setting, and even in a sexual context maybe. We talk about race as well, and again, as we saw, maybe the social determinants of risk, social disparities, health disparities, are sometimes specific to a race group. Some of the bigger, I will say, infrastructural policies may be, impacting a specific group of individuals based on a specific race. Then we talk about partners, right? One of the examples was about having a relationship, a main partner, and how they were not testing, but how when testing, the results are coming out more positive then. So look at how multiple partners defines risk, or how one main partner defines risk. We go into the behavior specifically, sex with men, with women, both. We've got to think beyond also kind of like our interaction. It's sort of like our identity, gender identity, sexual orientation, sexual behavior, because it differentiates. There are men who identify as heterosexual men who might be engaging in sex with men because of other social, economic reasons, and so forth. So we have to pay attention to this part. Condom use and not use condoms can be part of it, and so forth. So this is a brainstorming of who may be my target population, considering, again, what Michael mentioned before: predisposing characteristics, social structure, enabling resources, accessibility, availability, perception of need, and use of social services. So by creating this, I can then select that I'm going to work with maybe 21 to 30 who are Ecuadorian, who have multiple sex partners, with men who does not use condoms. And maybe other things about perceptions and knowledge and attitudes about HIV or condom use or sex, and so forth. And that helps me create what could be my segmented population. And here we have two examples, but from these we can create so many examples, and that can be kind of like overwhelming. But I guess a brainstorming can help narrow down. Do not have to put everything in place, but it helps you narrow down and see and test it in terms of this could be a population at risk. So we created two. One, African American man, age 25, self-identified gay, does not know his HIV status, engages in protected sex with multiple partners, lives in Hollywood, Florida, uses condoms all the time. So, and the other one, we have South American man, age 37, not self-identified gay man, does not know his latest HIV status, it's negative, engages in non-protected sex with single partner, meaning just one partner, that happens to be male, and lives in Tampa, and he is monogamous. Looking about the individual. So the question is, like, who is at risk? Would you say number one is at risk, a higher risk, let's say, or number two? And this is something you can put in your chat box, or you can, and we're going to unmute the line so we can hear your responses.
The conference has been unmuted.
Oh, okay. We hear number two. I'm up. That was great. So we have like comments around number two. As if can someone like elaborate more why two?
He engages in unprotected sex.
We have somebody who selected two in terms of more risk. A couple people said two, and then a person said one. Reason being, one needs to get tested, and in terms of number two, the partner needs to get tested. So therefore, he's at higher risk. Somebody says, shared, we cannot accurately tell if this partner is faithful. Okay.
Number two, it's the unprotected sex because we don't know if the partner, again, is being monogamous. So we're talking about the interaction and the relationship. So this is sort of like, and it's interesting to know that even that we are guided by the limited information that we have here without necessarily putting the environment in, but we are like 10 more to, I will say, 2 for the responses of because it engages in protected sex, because it's protected sex with multiple partners, and uses condom all the time. So, you know, when it comes to the information that, and we can go furthermore, and I put, and we have the dotted lines here because we're going to put the context of it in terms of the environment, and we will see maybe a difference. Maybe 1 is more at risk, even though these things happen, and maybe 2 is less at risk. There's other circumstances. So, but what this takes us is to a conversation of creating these kind of like profiles of our risk populations, you know, that helps us narrow down and kind of like getting formative assessment in talking, in going to a community, mapping the community, engaging gatekeepers in a conversation about the different circumstances, talk about members of the at-risk populations, and kind of like dig a little bit more in terms of information as well as observation. But another thing that helps us is also define what we call the screening and protocols. So we're going to go ahead and mute the lines now, and we're going to come back.
The conference has been muted.
So one of the things that we would like to emphasize in terms of kind of like screening for at high-risk populations is that it may be an adaptation of potentially the screening form that you have to include the different characteristics that you have given to your target or at high-risk populations. That include, again, the social structure, the enabling resources, perception of need or use of health services. So by creating this, it helps you kind of like screen in potentially a more targeted way the individual that is accessing the testing services, or the individuals that you are recruiting to go through the testing process. Sort of like, so are we just screening for behavior? Are we screening for personal characteristics as well? Are we screening for environmental factors? So I think, and we believe that more detailed screening needs to be created that goes along with your protocols. And this is kind of like the controversial thing that is happening in terms of, should we test or not test the person based on the screening? So, and this is, you know, we are a community-based organization. We engage in this conversation. We do testing here. And the conversation has come up in terms of, you know, I need to be targeted, I need to do a certain amount of testing, and I have a seropositivity rate. And again, if I'm not being successfully screening individuals, then I may be testing individuals that are not necessarily at high risk, and therefore my seropositivity rate is going to drop. Whereas if I do a screening that is very targeted together with other services that I can refer this individual to other testing, then I'll be a little bit more, I guess, targeted in finding positive and sort of like reaching my seropositivity rate target. So, but it's sort of like, again, the conversation of what's the screening, how does this relate to protocols, and vice versa. Sort of like how protocols relate to the screening that I have. And also, you know, from the should we test or not, we go into, should they go into these interventions? Should I do retesting? Should I go into referral services? So what's my protocol based on the screening that I do? This is something that I think it's the conversation that is happening in terms of, okay, how do I need to adapt what I receive to reflect the population that I'm targeting, and whether also I can find someone from this screening that can give me access to the network.
So again, it's really looking at, looking at the changes, high impact prevention or enhanced testing. It's all about enhanced testing, right? And we talked about sort of what that could potentially look like. It's all about finding, quote-unquote, or testing, I should say, testing the quote-unquote right people, right? And so we're being asked to be more specific in terms of who do we test, which then brings the question, so if we're invited to screen candidates and potentially deny, let's just say client A comes in, always uses condoms, has maybe multiple sex partners. We'll define multiple sex partners as perhaps 3 a year, right? Again, how you define sexual partners is up to the agency, and it is subjective, and that's what this conversation is about. So how do you use, what criteria can you use potentially to screen candidates, assuming you choose to do so? Again, we're not saying this is what you need to do. This is up for discussion. This is where high impact prevention is moving, is to sort of be strategic and use characteristics to potentially screen people and say, okay, perhaps we'll test you today. Assuming the situation does not change in 3 months, then there's no need for you to get tested, right? Again, we've been taught to stay away from that. We've always been historically encouraging routine testing, right? And I think this is what makes it so critical and also, controversial, because we're sort of retraining ourselves. And again, these are the conversations that there is no specific answer. There is no this is the right way of doing it. But it certainly opens up the space to have that conversation. And what would a potential screening tool look like? If I'm supposed to be targeting, quote-unquote, the right people, again, those people who don't know their status, those people who've never been tested, how do I do that? And am I testing, again, the question comes up, am I testing, are those routine testers at any higher risk, or are they, routine testing, again, is adapted. Many people do it because it's what we've been taught to do, regardless of circumstances changing, right? So it gets you to think more about what is risk and what is not at risk, and this is what this slide is about, and how to form that, how to potentially change, modify, or enhance outreach efforts that you've already been implementing.
And it's very specific. I mean, there's no overarching tool that is gonna kind of like provide. I mean, the information. It's sort of like something that we, as experienced as we are in our field and the population that we work with, can kind of like create and navigate and sort of like potentially find that person. And this is what it comes with, sort of like the partnerships and alliances, that it's not only necessarily about or other organizations or other referral services, but an individual that can be kind of like that peer, I'm not going to use peer navigator, but that person that helps you navigate into a specific network, and that was based sort of like maybe on the screening. So we have a couple of questions here, and it's about how do you reconcile enhanced testing right people with routine testing?
Your question. I'm going to open up the lines. We're going to mute the lines, and this is up for discussion. I would also love to hear.
The conference has been unmuted.
Okay, so the question again is, how do you reconcile enhanced testing or testing the right people with routine testing? Again, that's a great question, and it's really looking at who, or it addresses the fact of who is retesting, right? Because again, this is earlier I mentioned about customizing our efforts, and this is what I'm talking about, is that the efforts certain efforts we can potentially quote-unquote universalize or make this best practice, but many times, especially because we are working with different communities and different communities have different needs, we also have, that has to be captured and that has to be customized. So keeping that in mind in terms of who is being retested, what criteria am I using, how am I defining risk versus, or high risk versus not risk versus low risk, right? And so it really is up to the agency to best decide what are the protocols that they're going to put in place and how are they going to implement those protocols and what are they going to do in terms of quality assurance. So what does quality assurance look like? What does, if you are modifying or implementing a new strategy for testing, how long are you going to wait before following up, right, or checking or assessing progress or assessing how effective it's being done, right? And again, this is continuous assessments. We mentioned it. It's a continuous process. So it's you know, lack for a better word, trial and error. We're being asked to think outside the box. We're being asked to find positives, right? What we've been doing historically, data shows us is not working. So how are we changing it, right? And again, it's that continuous questioning of who this population is. How am I defining at risk, and what testing protocols am I putting into place to address this need in the community to get more people tested? So thank you so much for that question. I would definitely love to hear from another participant in terms of answering that question, or what are your thoughts about that? What are your thoughts about reconciling enhanced testing with testing the right people?
But see, what I said in the car when we was on our way back from South Carolina, North Carolina, wherever we were, I'd have stopped you in your throat. First of all, because it ain't about you. It's about JJ, and it's about probably being...
So another question is, who do we test and how often...
and see, that kind of...
risk. Thank you. Who do we test and how often is that based on risk? Again, it goes back to the original that premise of customizing our efforts and customizing our strategies. It's what does that population look like? Like, for example, you know, prior to joining the commission, I worked for a local provider doing HIV testing, counseling, and so I can tell you a little bit about what that population looked like and what the needs of that population were. But mind you, this is the South Bronx, so it's going to look very different from Central, South, or Northern Florida. And again, it's about what data do we have, what information do we have access to, what are people telling us, what are we capturing in those forms, in those intake forms, risk assessments, and how is that information, how are we using that information, and how can we, again, use it to enhance.
That's about you and that white girl. Don't get me started.
Oh, we're going to
don't get me started.
Ask you to mute your lines, one individual.
The conference has been muted.
So yeah, it's about customizing our efforts. And yeah, there's no one size fits all, and that's really what I want people to take away from this, is that it's not one size fits all, and that's where both the challenge and the opportunity lies, because it is challenging, because we're being asked to look at our information differently. How are we using our data differently, our information differently, and how are we sort of potentially implementing best practices with that information, right? And what questions are we bringing up? What are the potential solutions? And again, this is certainly team efforts, and we're going to talk a little more about what strategies we can implement, how can we potentially change protocols at an agency or within an organization of agencies to address some of these issues. And that's going to be, we're going to focus on that more in the third part of the webinar series, because it's certainly important, and we realize the challenges that lie ahead. But there are certainly tools that we can start using now, and frames and lenses that we can use to think about this a little more and unpack it. And I have another question. What are some ways to refine testing when testing by a risk group and finding STDs, but not HIV in the low prevalence rural area? Ways of redefining testing. So I'm let's see.
Well, I want to answer what we are going to this last one in terms of the who do we test and how often based on risk. This is where also comes the combination prevention or the prevention toolbox. This is sort of like kind of like disengagement. You now either found the person was HIV positive and or HIV negative. If it's HIV negative, then because of the screening that you did and because of all the segmentation that you did, this person is considered based on that at high risk, negative. So you see in the combination prevention or HIP, the toolbox, it's about maybe linking them to specific behavioral interventions and or structural interventions, which might be some sort of CRCS maybe, or condom distribution, which is a structural one. Here's where that combination comes from. And then again, your protocols and the screening and this combination should define, how often. But we know sort of like in terms of guidelines, the window period and all that, and how often the person should be tested. That should be part of it. That's why, the screening and protocol relate to each other. In terms of the first one, the reconciliation, here's what kind of like maybe goes back again to the screening and protocols and the actually evaluation of this data that we collect in terms of defining who among the people that, yes, we put them potentially as high-risk individuals, but end up being routine testers, and you kind of segment and kind of like divide that information that you receive, and then provide the appropriate channels in terms of linkages to these individuals. For those who you have determined that are routine tester, what are the linkages, referrals, and the potential interventions for these individuals, and those who are and testing the right people, well, that will, again, like we saw before, you have the options of linking them to the prevention toolbox in terms of at high-risk negatives and or for positives, what needs to happen in terms of linkages and maintenance in care. In terms of some ways to refine testing when testing by risk group and finding STDs but not HIV in low prevalence rural areas. So there are a few keywords here. We're talking about network pools, right? Low prevalence. We have to go and assess, there are STDs, but like we saw in the example here, in defining this, these persons may be HIV negative or do not know the HIV status, and they engage in unprotected sex. But what happens is that the network is closed, so they might have interaction with each other at different levels, and they don't go outside that network. So what will happen is, enhancing or refining is to find out whether this network goes outside that pool, and that one person may kind of be the link. This is what sort of like this social networking part of it happens. So it's sort of like go a little bit more in depth about assessing what are the circumstances that are happening here, that there are STDs, that can be transmitted, from each other in this network pool. But if none of them is HIV positive, that's not going to happen. Now, if they go outside of that network pool, then it's a whole lot different story. So it's a little bit more refining, and that goes into kind of like this segmentation and the environment. So when we look at the environment, we have to live in terms of refining testing with these individuals. But and again, some of the keywords were here like low prevalence, maybe none within this group, and maybe they're not accessing those pools.
Any other questions or comments? We'll go ahead and mute the lines.
The conference has been unmuted.
So, as part of kind of like the next steps and homework that we were we're going to provide, and it's recommended, we're going to send you this information, and we recommend for you as a team to kind of like brainstorm on this. We're definitely going to send you these slides that you can refer back to. We're also going to send you information on the different research that we have used to like put together the concept of structural barriers, risk and pools, network risk pools, and relationships. I may have some videos that came from the International AIDS Conference, because this is sort of like based on the Lancet MSM series. We're going to ask you to kind of like go and engage in this process of defining and creating maybe 2 or 3 populations that may be at high risk based on individual things for now, the predisposition, enabling resources and needs, and furthermore, what will your screening and protocol would look like. And if you can send us that, because the idea is sort of like to kind of showcase your expertise and your experience, and also maybe refine some concepts that may not be completely explored based on your realities. As in a training setting, we will like put you in groups and have you come up with kind of like these target populations and a screening protocol. We're doing this as a kind of like an exercise. And if you can we'll send you the instructions, send it to us on Monday. We will incorporate this in the presentation, and we will go over it. So, and then we'll be ready for the next 2 sessions. The next one is happening on Wednesday, a week from today, and which is September 11th, same time, 10:30 to 12:30. You don't have to register. During the registration, you provided your emails. We'll send you the link to come into the webinar. And we will do that for the 2 sessions, the one on next Wednesday on the 11th, and the last session on the September 18th. You will also have the information to contact us if you would like more or additional information that, sorry, we didn't, or we missed to send. But we're going to send these slides. We're going to send you the homework information. There's already a workbook, and the link is and the linkages to the resources in terms of the research. Are there any last questions? Okay. So with that said, we thank you so much for being part of this first session on the curriculum of Finding Positives. It's, again, we would love to hear or get your input. We would like to customize it as much possible, being that it's long distance, and reflect your experience and expertise. As I said, this is a collaborative effort, and your input is really appreciated because it helps us understand the realities, and it also is good as a peer sharing information.
Absolutely. Thank you so much again for joining us today, and really, especially, you've been an awesome, very engaging group of participants, and thank you for the questions. They really do fuel the conversations and allows us to all learn from one another. And again, being able to really customize this for all of you down in Florida, we know we're doing great work, and continue to really use your efforts in addressing the needs of the community, and also effective interventions. So again, here we have our contact information. Just to reiterate, we will send you the link. So you do not have to register again. You'll get the link that will allow you to join the conference session, which will take place next Wednesday, same time. same time, same place. And yeah, thank you again for joining us today.
And do please share your homework. I mean, we won't hurt who came from. We just compile the information, we put it into slides, and we go over it. Right? Thank you so much, and have a great afternoon.
Thank you. Please stand by.